So I've covered the 3 topics. So basically, all I need to do is revisit the 3 topics or anything that you guys are stuck with or is you finding difficulty dealing with. So let me know. Either we can just do OBS history taking, Gynae history taking, or terminology one, or whatever you guys want. If you have any queries related to them, we can take that as well. Or I can just take the terminology presentation, and then if you guys are stuck anywhere, we can take it from there. So guys, at least 1 or 2 students should put in some feedback. Urdu. Urdu, that will be very difficult. Urdu. Guys, Urdu में तुम लोगों ने क्या करना था और एग्जाम में उर्दू थोड़ी चलेगा था English. I can tell you more or less. I know. It's a clinical posting class. So, let me just then browse over the obstetric history taking and then gynae history taking. So, hope you guys had a fine day so far. My name is Dr. Sanam Imtiaz. I'm an assistant professor in urogynecology in DMT Gynae Unit 1. Okay. So these are generally the principles of history taking. I don't think I need to get into the details of that. You all know it already. They apply for any kind of history taking, be it gynae, medicine, surgery, any other specialty, okay? So respecting confidentiality, privacy maintaining, information should be in a logical and chronological order. And history should be able to guide the clinician what the provisional diagnosis and management would be. What is important? Build a rapport with your patient, make a provisional diagnosis, offer relevant investigation, start treatment, pertinent counseling. Prerequisites as always. These are the important things. These are the important things. These are part of the key of your OSCE stations. Don't miss out on them. Always introduce yourself. Always tell your name, that you're a doctor. Seek permission from patient that may I ask you a few questions. Always ask the patient if there's somebody they would want to come along. Especially if you're a male doctor. So you should always ask for a chaperone. So these are few things that you all should, offer to the patient. Then always ask the patient, what do you know about your disease? In the end, always thank the patient and ask the patient if there are any questions that you would like to ask. तो ये general है, rules हैं जिनमें points मिलते हैं, ठीक है? Dress code should be appropriate. You should be gentle, sensitive, and empathetic towards the patient. Then what is particular or pertinent in obstetric history taking? This is general biodata. Name of the patient's age, the marital status, duration of marriage, husband or partner's name, occupation, and address. Pertinent. We've already discussed this in quite a lot of detail. Parity. What is parity? Parity is divided into 2 numbers. One is written first, then the other one plus. So parity, the number which is written first is less than more than 24 weeks of gestation, 24 weeks and onward. Whatever the outcome would be an IUD, would be an early preterm or anything. That would come below a number, okay? And the plus and the additional number that we write on the top is always the number which is less than 24 weeks before the age of viability. And for twins, parity is always 2. So parity is basically the number of pregnancies, and gravida is the time of the number the female gets pregnant. So in parity, pregnancies for twins would be 2, but gravida, the time of numbers woman got pregnant would only be 1. So that you always understand. And for in gravida, you always mention or add the current pregnancy as well. LMP is the first day of your last menstrual period. Calculation of EDD, like I told you, add 7 to the LMP, add 7 numbers, and you calculate the date. Then after whatever date or month you get, after the calculation, you will add another 9 months to that. So that's how you calculate EDD. Pregnancy planned or unplanned है. उर्दू में तो आप क्या ये प्रेगनेंसी चाह रहे थे, नहीं चाह रहे थे, क्या इसके लिए आपने कोई दवाई ली, नहीं ली, क्या आपका हस्बैंड या आपका शौहर आपका रिश्तेदार है, नहीं है. And I don't think so I really need to tell that. I think these are all understood stuff. In exam, you have to say in English. It's not Urdu. Counseling has to be in English. It's not Urdu again. अवार्ड में आप कर सकते हैं मैनेज, प्लीज गाइस। इनमें से कुछ पूछना हो तो मुझे एंड में क्वेश्चन है पूछना, आई कैन रिपीट दैट अगेन. Again, presenting complaint, you always write down the gestational age. How do we calculate the gestational age? Gestational age is that you calculate from the LMP till the current date. How many weeks would that be? You put in the number of weeks and reason of presenting in OPD, emergency department, whatever. Like, for example, 24 weeks came to OPD for routine antenatal checkup. 24 weeks came to emergency with PV bleeding. 28 weeks came to labor room with decreased fetal movement. So these are just examples. Multiple presenting complaint, again, you would always write down in chronological orders. History of presenting complaint, you know that you elaborate each complaint in detail in chronological order, along with what action has been taken, any improvement, if any, was hospitalized, what treatment was given, what investigations were done. So a complete and thorough history of what the current illness is about, any relieving symptoms, any aggravating symptoms. Or pertinent disease-related questions. For example, if a patient presents to you with a history of raised blood pressure at home, and she says that I'm having frontal headache as well, then you know what are the other symptoms of preeclampsia, like epigastric pain, decreased fetal movement, nausea, vomiting. So you would ask these then focus questions to the patient. And then, for instance, the patient comes with pre-prom history of leaking. Then you would ask the duration of leaking. Was it watery? Did your clothes get soaked? Or was it like a discharge, little amount, was it blood stain or not? What the worst color of the discharge was that? So you can differentiate between a normal vaginal discharge or pre-prom. Pre-prom is just leaking. That is preterm, pre-labor rupture of membranes. Obstetric cholestasis is jaundice and pregnancy, decreased fetal movement. I'm sure these are your few initial classes, so you guys wouldn't be knowing about it. Then in OBS history, you always take a trimester-wise history. You will always ask about the patient. These are general to all trimesters. Any particular, ask particularly about any issues occurring in each trimester individually, like bleeding, discharge, fever, urine bowel problems, any other illness. You always ask the patient कि आपको शुरू के 3 महीनों में कहीं ब्लीडिंग तो नहीं हुई थी, कोई पानी की शिकायत रही थी, पेशाब में पखाने में कोई मसला तो नहीं था, या फिर आप दवाइयाँ ले रही थी कि नहीं ले रही थी, कोई इंजेक्शन लगे थे नहीं लगे थे, आपने किसी डॉक्टर को दिखाया था नहीं दिखाया था. So these are general questions that you would ask in any trimester that patient is presenting to you. फिर फर्स्ट ट्राइमेस्टर में स्पेसिफिक क्या है? हाउ डिड यू कंफर्म द प्रेगनेंसी, बाय व्हाट टेस्ट? क्या कोई अल्ट्रासाउंड करवाया था जिससे पता चला हो कि प्रेगनेंसी है? कहीं बुक हुई हैं नहीं हुई हैं? चेकअप्स करा रही हैं नहीं करा रही हैं? अभी कोई आयरन कैल्शियम या कोई दवाइयाँ ताकत वाली ले रही हैं नहीं ले रही हैं? उल्टी मतली हुई थी, कब तक हुई थी, कोई दवाई लेने की जरूरत पड़ी थी, अब तक कोई टेस्ट हुए नहीं हुए हैं? फिर आप आ जाते हैं सेकंड ट्राइमेस्टर में. तो दीज आर द पर्टिकुलर क्वेश्चन दैट यू वुड आस्क इन ईच ट्राइमेस्टर. जनरल क्वेश्चन तो आपने हर ट्राइमेस्टर में पूछने हैं कि पहले ट्राइमेस्टर में ये तो नहीं हुआ, दूसरे में डिस्चार्ज, ब्लीडिंग, यूरिन बाउल को कोई प्रॉब्लम तो नहीं हुआ, फीवर तो नहीं हुआ. तो वो जनरल क्वेश्चन है जो हर ट्राइमेस्टर अप्लाई करेंगे. ये स्पेसिफिक क्वेश्चन है. क्विकनिंग यूजुअली स्टार्ट्स इन सेकंड ट्राइमेस्टर अराउंड 20 weeks and onward. In a primate or in a multiple, it can start even earlier. So these are the initial fetal movement that I felt कि क्या बच्चे की कोई हरकत महसूस होना शुरू हुई है. फिर दोबारा कंफर्म करेंगे द पेशेंट हैज बुक्ड समवेयर और नॉट, अल्ट्रासाउंड कोई करवाया है नहीं करवाया है, उल्टी मतली अब तक है खत्म हो गई है, कोई सप्लीमेंट ले रही हैं कि नहीं ले रही हैं, वैक्सीनेशन का स्टेटस, यूजुअली टेटनस इज गिवन सेकंड ट्राइमेस्टर ऑनवर्ड. In third trimester again you will ask if any scan was done, vaccination completed or not, शुगर का कोई टेस्ट हुआ था क्या नहीं हुआ था, क्या आपको बताया गया डिलीवरी का क्या तरीका होना है, कब होना है, कहाँ होना है, बट आपको क्या पता है अपनी बीमारी के बारे में या बच्चे के बारे में. अब पास्ट ऑब्स हिस्ट्री जो ऑब्स्टेट्रिक में होते हैं हम लोग बहुत डिटेल्स में लेते हैं. I've already discussed that earlier as well, that you would take a detailed outcome of each pregnancy in a chronological order. Date and time of delivery, what was the gestational age at the time of that delivery, what was the mode of birth, what was the outcome, was it a live birth, stillbirth, miscarriage, ectopic, what was done about it, what was the fetal weight, the gender, the ABGAR, if there were any complications at all. So this is one of the formats. Or like for some mother's age, we don't usually put mother's age, you usually put years of birth. Then this is if this has an abortion, how many weeks was it, what was the place of delivery, what was the duration of labor, mode of delivery, sex, outcome of the fetus, were there any complications? Okay, so then menstrual history, you'll just take a brief history. LMP you've already asked. What are the durations of cycles? Were there regular cycles or not? Was the flow normal or not? Was there any pain associated to it or not? So in menstrual history, it just has to be brief, 2-3 liner. That's it. Contraceptive history, the type of contraception that was used, was it effective or not? What were the major side effects of it, if any? In past medical history, you'd ask what kind of medical comorbidities that patient has. कोई बीमारी तो नहीं है आपको जिसके लिए आप रूटीन में दवाइयाँ लेती हो, ब्लड प्रेशर, शुगर, दमा, टीबी, कैंसर, गुर्दों का मसला, दिल का मसला, ऑल दैट. किसी चीज़ के लिए आप खास तौर पर कोई दवाइयाँ ले रहे हो, कभी कोई सर्जरी हुई है, कोई भी किस्म का ऑपरेशन हुआ है. फैमिली हिस्ट्री में व्हाट आर रेलेवेंट इन ऑब्स. मदर को डायबिटीज है तो डॉटर को डायबिटीज होने के चांसेस हैं, जीडीएम होने के चांसेस भी हैं. Mother had preeclampsia, the daughter can have preeclampsia. So these are relevant. Comorbids पूछे कि family में क्या चल रहा है. Chromosomal defects can run in family. Bleeding disorders can run in family. Congenital defects can run in family. Multiple gestations can run in family. So more or less what you're taking in family history are all relevant things to OBS. However, you do take a general OBS for यानी family history. आप हर किस्म की history में general लेते ज़रूर हैं. बाकी में ड्रग हिस्ट्री लेंगे, क्या दवाइयाँ लेती रही हैं पास में, क्यों ली, किस लिए ली, किसी चीज़ एलर्जी है. पर्सनल हिस्ट्री में कि नींद सही आती है, खाना सही खाती हैं. सोशल हिस्ट्री होगी, कमा के कौन रहा है, कितना कमा रहा है, किस घर में रह रहे हैं, सही गुजारा चल रहा है, लाइफस्टाइल ठीक है. Then antenatal card, okay. This is an antenatal card. It's not the one that we have over here in our wards, but more or less in a standard antenatal card, these are the things that would be covered. What gravida is it? What is the ED? The blood group of the patient. For delivery at, what is the plan? If the patient is high risk or not, you would tick that. And then what's the surname, given name, address, date of birth, phone number, partner's name, support number. ये सारे international पे ज़्यादा होता है support number वगैरह, partner name. Then ये past ops है, देखो this is better. What were the years of birth, या years of delivery, or years of whenever the outcome of the pregnancy happened. What was the gestational age? Was it 6 weeks? Was it 24 weeks, 28 weeks, 34 weeks, whatever the weeks were? Was it an alive stillbirth, NND? What was the sex? What was the birth weight? The type of delivery, place of delivery, any additional information. Any additional information you can always mention. It was if it was a miscarriage, then it was medically managed, or evacuation was performed or not, or if patient went into PPH, or if patient had APH or retained placenta, anything, or blood transfusion was required. All these things have to be mentioned over here in comments. Past medical history, pap smear done or not, what was the result, then on examination, तो examination section आ जाएगा. Family history में आ गया, then drug history आ गया, addiction है कि नहीं है, booking done or not. फिर ये नीचे आ गया कि जनरली ये इस अभी का हो गया कि menstrual cycle कैसी है. फिर ये अभी हो गया कि अल्ट्रासाउंड कौन कौन से हुए, index pregnancy performed by date and all these things. This is also not mandatory in every antenatal card. So these are customized antenatal cards. Antenatal cards are usually made by the hospitals and they have their own policy, the OBS department, and they decide. So this is more or less covering the index pregnancy. These are the dates of the visits of patient. What was the blood pressure at the time? What was the weight of the patient? If there was any edema, what was the height of fundus? What was the presenting part? Fetal heart rate was normal or not? If the patient had any complaint of vaginal discharge, tetanus toxoid received or not? She's taking any iron supplements or not? Any kind of remarks, the doctor who's saying it, when to follow up, all these kind of things, okay? Then birth plan, always by third trimester near the end, depending if the patient is a low risk pregnancy or if she has any high risk, what is the plan of delivery, the place of delivery, who will deliver, any special instructions if there are at all. You would always write that down in your antenatal card. So whenever the patient presents in labor room, she would be received by somebody else. The primary doctors usually are at home or are somewhere else busy. So the receiving doctor usually PGs, postgraduate trainees over here and outside as well, or HOs. So whenever they receive the patient, they at least have this idea that what is the primary plan of this patient by the primary doctor. If there are any high risk in this patient, or if there are any special instructions for this patient. So you should be mentioning that. Then in postnatal care also, you can also, this is a card after the discharge, after the birth plan, that you would mention this, and you would mention if any kind of supplements that should be given or any contraceptive planning that has been given, and this is a choice that patient has made. So this is how you cover it. So let's take questions on obstetric history, and then if you guys want me to cover, I can cover gynae history or the terminology presentation, either of the two. Let's take question on this one so that at least we can clarify as much stuff as we can. Guys, any questions so far? Why am I not seeing the chat section? Guys, questions, jaldi. And then if you would want me to go through the gynae history, I can do that as well. Okay. You guys are clear with the parity and the gravida वाला part, right? EDD, parity, gravida, LMP. ये चारों terminology तुम लोग की बिल्कुल crystal clear होनी चाहिए, ठीक है? I hope you guys are clear on that. Last time मैंने करवा कर देखे थे. You want me to cover gynae history? I can do that. You want me to cover the terminology वाली presentation? I can do that as well. You guys think more or less the history taking will be, you guys will get more familiar once you start seeing cases. Then you would just vaguely ask. For instance, if a patient said that कि हाँ डेट ऑफ बर्थ मुझे नहीं याद है लेकिन 6 साल की, अक्सर मारते हैं ऐसे आती हैं जिनको नहीं पता होता 6 साल की होगी 5 साल की होगी, so then you would just estimate and write down like 6 years back or 6 years back. You just write that down. You don't need to really put in the date or anything. So you just basically provide the information in your history taking which is provided to you by the patient. LMP, maybe if patients mostly don't remember, then you write down not sure of dates, but you do try to dig in. You do try to, you know, like relate it to the Islamic calendar and ask like Ramzan से पहले थी, ईद से पहले थी, कितने महीने पहले थी, आज से कितने महीने पहले थी, आपके ख्याल में कितने महीने हो गए हैं. So these are few ways that you can, you know, at least try to dig into, at least, you know, present something in a normal way, or at least in an organized way. Anything else, guys? Any more questions, guys? Bacha party? Any more questions? How come you guys are just 188 in your class? Are you guys 188 or you more than just 188 attending the lecture? Because when I take 4th year lecture, they usually go up to 300 as well. So I'm not sure. Okay, so what do you guys want me to do? You guys want me to recap gynae history? You guys want me to recap the terminologies? I can do whatever you guys want me to explain to you. Like somebody earlier asked for both the history, so I can do that as well. I can move on to gynae history. Time is money. Jaldi batao. Terminology. Even I think terminology would be more appropriate. History, tum log with time you'll understand better. Chalo, let me move on to terminology, okay? फिर टाइम बचेगा तो देखेंगे gynae history के लिए. Antenatal is before birth. Fetus is the baby that is given. Gestational age is calculated from your last menstrual period, the first date of last menstrual period, and you calculate the weeks that have passed by till the current date. So whatever the current date is, you calculate till that date. LMP was the first day of the last menstrual period. Expected date of delivery is calculated by adding 7 to the last menstrual period date to the LMP, and then whatever date and month is calculated, then you just add on 9 months to that. So that's how we calculate EDD. Gravida, number of times a woman got pregnant despite of the outcome. Primary gravida, like first time pregnancy. Multigravida, second or more pregnancy. Parity, the number of the times woman, it's not delivers, you would say, it's the number of the time woman, the number of pregnancies to be more appropriate. Parity, number of pregnancies. Either after viability plus number of pregnancies or lost before viability, that's less than 24 weeks. In primary para, it's first pregnancy. Trimester, we divide pregnancy in 3 trimesters, first, second, third. It's always like 3 monthly, almost. Quickening is the initial movement that are felt by a mother. Amniotic fluid is the liquid that is around the baby. इसको लाइकर कहते हैं आम ज़बान में, ठीक है? And that's it. Amniotic sac is the sac surrounding it. Amnion layer, we know that. In labor terminology, that is term pregnancy. What is term? Term is 37 completed weeks. From 37 completed weeks till 42 weeks, it is called as term pregnancy. Less than 37, preterm. Term se pehle is pre. Term ke baad is post. The post term after 42 weeks. First stage of labor is when, with the onset of labor till complete dilatation of the cervix, is called as first stage of labor. What is the onset of labor? When does labor start? When there are regular contractions, regular painful contractions of more than 3 per minute, more than 3 in 10 minutes, and lasting for at least 30 seconds each is called as active labor. So when contractions develop in a proper way, from that time till 10 centimeter of full dilatation is first stage. From full dilatation to the expulsion of the fetus is second stage. After the expulsion of the fetus, delivery of the placenta is the third stage of labor. Trial of labor is a term generally applied for women who've had a previous cesarean section, and when you give them a trial of normal delivery, you call it trial of labor. Induction is when a woman is not going into spontaneous labor and you would give her artificial techniques to induce labor or to start labor. It is called as induction. Sorry, let me go back. Sure is just a mucus discharge. It's a thick mucus discharge which comes out from the cervical canal, and it's usually blood stained, and that would just be a sign that labor might start in a few days or a week. The patient is being prepared for labor. Non-stress is CTG. It's basically a detection tool of fetal well-being. Artificial rupture of membranes is in labor. When the membranes are intact, you want to expedite labors by rupturing the membranes. So you rupture the membranes artificially by using probes, and that is called as artificial rupture of membranes, or ARM. What is PROM? PROM is premature rupture of membrane. That means labor had not yet started. Patient has not, she's not having regular contractions, but she started leaking at home. She presented with leaking. That's called as PROM. And if that leaking happened before 37 weeks, that is before term, that will be called as preterm, pre-labor rupture of membranes, or pre-PROM. Breech presentation is when the presenting part is buttock. When the presenting part is head, it's called as cephalic presentation. Station is the presenting part in relation to the ischial spine, and this is assessed vaginally. If it is at the level of ischial spine, it is stage 0. If it comes below that, it's +1, then +2, then +3. Engagement is when the widest diameter of the presenting part crosses the pelvic inlet. Crowning is when the head or the presenting part is stuck and it does not recede back. Meconium is the first bowel content of the baby that is passed at the time of birth. Membrane sweeping is a method of induction of labor or triggering labor by sweeping between the membranes and the cervix and the uterine cavity. So that basically relieves prostaglandin and can trigger uterine contractions. Epidural is a way of analgesia given in the epidural space, and drugs are injected by the anesthetist. Episiotomy is a cut given in the perineum to allow birth to the baby. Cesarean section is cesarean section, any delivery by applying an incision on the abdominal wall and the uterine walls. NVD or SVD, spontaneous vaginal delivery, or normal vaginal delivery, is a vaginal delivery spontaneously happening. That means when you say spontaneous vaginal delivery, it doesn't mean that ARM was not done or oxytocin was not given. These all things were given or might have been given or might not have been given. It doesn't matter. But patient basically delivered spontaneously through the vaginal route. And if instruments were used to facilitate this vaginal delivery, that could be in the form of ventouse, which is a vacuum cup, or forceps, which are applied laterally. So it could then called as instrumental or assisted vaginal delivery. VBAC, vaginal birth after cesarean section, is a patient who delivers normally after having a last cesarean section. That could be the last pregnancy or prior to that pregnancy. For instance, a patient had first child by normal delivery, second child by cesarean section. Then she had a normal delivery. Now in index pregnancy, again, she delivers by normal delivery. So she will also be called as VBAC. So it is despite of the fact whenever she had the cesarean section, but if she's had cesarean section in the past, so even if she's had 2 normal deliveries after that, she will still be called as VBAC, vaginal birth after cesarean section. Pregnancy-induced hypertension is raised blood pressure in pregnancy after 20 weeks and onward. Less than 20 weeks is chronic hypertension. I'm repeating, after 20 weeks, if the blood pressure in pregnancy is raised, it is called as PIH, or pregnancy-induced hypertension. If with raised blood pressure, there is proteinuria, we call it as preeclampsia. If with preeclampsia, the patient has seizures or fits secondary to preeclampsia, we call it eclampsia or eclamptic fits. What is gestational diabetes? Gestational diabetes is any derangement in the blood glucose levels throughout the pregnancy. It has no cutoff of any gestational age. It can happen in first trimester, second trimester, third trimester, anytime, and it will be labeled as gestational diabetes. Macrosomia, when the growth of the baby is above the 95th centile or the percentile of the expected gestation or expected growth for her gestational age. SGA likewise is below 10th centile. IUGR is when the growth is small and the blood circulation to the baby is compromised. You call them as IUGR or intrauterine growth restriction. Polyhydramnion is an excessive amount of liquor. Usually it's more than 8 centimeter of deep vertical pocket. Oligohydramnion is a decreased amniotic fluid, less than 2 centimeter of deep vertical pocket. Antepartum hemorrhage is a hemorrhage or bleeding vaginally occurring during the antenatal period, that is before the birth. Placental abruption is when antepartum hemorrhage, when bleeding basically happens or occurs because of detachment of the placenta from the uterine wall. That is called as abruption. Placenta previa is basically the placenta is low lying. It's either reaching the os or covering the os. Morbidly adherent placenta is when the placenta is invading into the myometrium or has crossing the serosa. It is called as accreta, increta, or percreta. Accreta is when it crosses its main, the endometrial lining, it goes deep into that. Increta when it enters the myometrium, and percreta when it crosses the uterine serosa. It might invade into bladder or so far, wherever it is. Lochia is just the amount of the discharge, is the discharge or the bleeding that a woman faces after delivery of the baby. It can be from reddish to pinkish to even pale color later on, and usually it lasts for a duration of 45 days. Miscarriage is basically loss of pregnancy before 24 weeks of gestation. So if less than 24 weeks in parity, it's written above, plus के बाद जो आएगा वो miscarriage, if whatever, less than 24 weeks ऊपर आएगा. Multigravid has more than one pregnancies. Contraception is a method of birth control. Ectopic pregnancy is a pregnancy that develops somewhere outside the uterus. It can be tubes, it can be ovaries, it can be pouch of Douglas, it can be in the previous scar side. All these are ectopic pregnancies, basically not in its normal uterine anatomical location. Hysterectomy is removal of the uterus. It can be done by abdominally removing total abdominal hysterectomy, or can be subtotal when the cervix is left behind, or can be a vaginal hysterectomy when the uterus is removed vaginally, mostly because of prolapse, or can be cesarean hysterectomy. When you do a hysterectomy, especially in cases of morbidly adherent placentas, you would do a cesarean hysterectomy to save the life of the woman, because the woman might bleed a lot. Just to save her life, and time is money at that time, is very precious, you would move on to performing hysterectomy in an obstetric patient after removing of the baby, after delivering the baby, that is. Radical hysterectomy is usually performed in cervical cancers, in which the parametrium, the vagina, and everything is also removed along with hysterectomy. Tubal ligation is a permanent method of contraception by ligating, cutting, clipping the bilateral tubes. Subfertility or infertility is a failure to conceive after 1 to 2 years of unprotected intercourse. In some guidelines, the duration is written 1. In some 2 years is written. I'm not sure what you guys have in your books, but both of them can be found as correct. And it can be primary subfertility when a woman has never conceived, or secondary when a woman has had a conception earlier and now is unable to conceive. It doesn't matter if the earlier conception was a miscarriage or if it was a live baby, doesn't matter. She's just conceived earlier once, whatever the outcome was. If she now fails to conceive, it's secondary infertility or subfertility. In menstrual cycle, what are the normal terminologies? Menarche is the age of the onset of menstrual cycle. Amenorrhea is when a woman has lack of menstruation. It can be primary, that is never had menses, or secondary is that was having regular menses but now has not had menses for a couple of months. Menopause is complete cessation of menses for at least an year. 1 year से पहले अगर है तो उसको हम secondary amenorrhea कहेंगे. 1 year crossed, it's menopause. Postmenopausal bleeding is when a woman has achieved menopause. That means for 1 year she has had no menses and then she developed bleeding or spotting. So that's postmenopausal bleeding. LMP is the first day of the last menstrual period. Dysmenorrhea is painful menstruation. Menorrhagia is heavy menstrual bleeding. Oligomenorrhea is infrequent or less menstrual bleeding. Intermenstrual bleeding is when the bleeding occurs in between 2 menstrual periods. Reasons बहुत सारे हो सकते हैं. COC is combined oral contraceptive pills, which is a combination of estrogen and progesterone. HRT is hormonal replacement therapy, supplements which are given to peri or postmenopausal female to resolve the symptoms of menopause. PID is pelvic inflammatory disease, or STI is the same thing. It's a sending infection of the genital tract from the vagina and upward. Ovulation induction is when a woman is infertile, and the reason is that she is unable to have ovulation. You would give her medicines to form eggs and then trigger ovulation. This is called as ovulation induction. Thank you, and now we can take questions. Guys, questions? Terminology is good. Everybody wanted to know the terminology. Questions. Do we have any questions? Guys, do we have any questions? Questions, kids? My initial CN4 slide में क्या था? मैंने just stopped sharing. Calculated from the last menstrual period, and its number of the weeks that have elapsed since LMP till the current date. LMP is the first date of the last menstrual period. Expected date of delivery, we've already discussed it a couple of times. If you guys want me to explain that separately, I can do that. Gravida, you know it. Number of the time the woman got pregnant despite of the outcome. Primary is first pregnancy. Multi is when she's already had one pregnancy. Now this is the second pregnancy or onward. Parity is the number of time woman. It's not the number of time the woman delivers. Basically, again, I'm correcting it. It's basically the number of pregnancies. That's the right word to do. Number of pregnancies after 24 weeks or after the weeks of viability, plus number of pregnancies before the weeks or lost before the weeks of viability. That is less than 24 weeks. That's how it is. Primary is first time pregnant female. Trimester is pregnancy divided into 3 trimesters. First, second, third. Quickening is the initial fetal movement that I felt. Amniotic fluid is the is the liquor that is present around the baby, which helps the baby in movement and growing and breathing and everything. Amniotic sac is sac surrounding that. Are these the slide, the 7th slide now? Were these the terminologies that you asked me to repeat? I can't repeat. I'm not. Let's get back to questions, right? Any more questions, guys? What the hell?